Okay, I think we'll make a start there. It's now 3:30. Good afternoon, everybody. Thank you for coming to today's webinar. We hope you find it useful. We've got lots to discuss today. So just to kick off with some housekeeping, we won't be allowing participants to share their screen or their video, or speak on today's webinar. If you'd like to ask a question, if you could use the chat function, which you can find at the bottom of your screen, it's a little speech bubble, and click there and just type the question in, and we will pick it up as the webinar goes along. And I know some of you are also watching on Facebook. If you are, just pop your question or comment in the chat box, and I have colleagues who will pass them over to me. I'm Charlotte. I'm the Patient Advocacy Manager here at Leukaemia Kerr, and I'll be chairing today's discussion. And I'm joined by a lovely bunch of nurses who hopefully will be able to give us some insight into what they do. So let's start with a bit of introduction. So top of my screen is Kirsty. Could you introduce yourself for me?
Hi, I'm the Advanced Nurse Practitioner for Myeloid disorders at the Churchill Hospital. I have an interest in all in hematology, really, but really I'm really interested in the symptoms that patients.
Your audio is a little bit fuzzy. I'm not sure why that is, but hopefully we can hear you for the rest of. Yes, that's a bit better. Thank you. Thanks, Kirsty. Sarah, you're next on my screen.
Hello, I'm Sarah Watmough. I'm a leukemia clinical nurse specialist and research nurse. I work at Clatterbridge Cancer Centre, Liverpool, in our lovely new hospital here. So I have quite a unique role, I think, compared to some specialist nurses, that I work as the research nurse, the clinical trial nurse for my patients, as well as being their specialist nurse. So it's a really lovely role, lovely job.
Great, and hopefully you can tell us a bit about the difference between the two, or the sort of two sides of that. That'd be really interesting. Caroline, you're next.
Hi, I'm Caroline Kerr, and I work in Belfast City Hospital. I am the leukemia nurse specialist here, and I also look after any myeloid disorders as well.
Thank you. Sorry, it would help if I unmuted myself, wouldn't it? There was just going to be one time that we did that. And Catherine. You're on mute.
There we go, sorry.
There we go, no worries.
I'm one of the specialist nurses at St James's in Leeds. I also look after leukemia patients and those with myeloid disorders as well. So quite a broad range of patients.
Great, thank you, Catherine. Just to help with the noise, if we could all try and be on mute when you're not speaking, that'd be really helpful. I think there's a little bit of fuzziness. I don't know if it's me, but just in case, that'd be really good. Thanks, guys. Okay, so what we're here to discuss today is the role of specialist nurses in the treatment of various different types of leukemia. And the reason we decided to sort of undertake this webinar is we were reflecting on a campaign we did a couple of years ago called My CNS Matters. And we found a few different findings in that sort of hinted at whether at how access to a CNS or a similar key worker has an impact on a leukemia patient's or blood cancer patient's diagnosis journey. I just wanted to share a few of those findings before we kick off. So one of the things I wanted to share was that the CNS can play a vital role in a patient's experience, in terms of, we found that patients were more likely to report understanding their diagnosis if they had access to a CNS. They were more likely to consider themselves informed about their prognosis. They were less likely to report feeling worried about their diagnosis. They were more likely to be offered a trial and more likely to join a trial. And they were also more likely to be offered additional support. Actually, 66% of patients without a CNS reported no additional support being offered to them at all. And by additional support, we mean things like support groups, buddy schemes, the things that we supply here as a charity, I guess, and signposting to more holistic care. So obviously that was a concern to us. And just to add that there are certain groups that are less likely to have access to a key worker or a specialist nurse. And we found those groups are the chronic leukemia patients, both CML and CLL, but also specifically watch and wait patients or active monitoring patients. So that's just for context to share with everyone today, that clearly a CNS can play a really important role in a patient's journey, and that's why we wanted to sort of discuss that role today, and hopefully the group can share their thoughts on why they think nurses are important. Before we kick off, I have got a couple of polls to run, which I will launch right now. So the first set of polls is aimed specifically at patients. If you are a patient and you're on Zoom and listening, if you could answer the following questions for us, it'd be really interesting to hear. The first question is, do you have access to a named person as a key worker? And then the second question is, if so, do you know whether that person is a specialist nurse or do they have another role within the hospital? And I'll probably give that just a couple of minutes to run. Some interesting results, positive results so far. Most people are saying yes, so that's good. We will leave it there, I think. The polling stopped. So 82% of people are saying they have a key worker, and most of those people are saying that it is a nurse, so that's positive to hear. And then while we start talking, there's a second set of questions. Just to confirm who we've got in the audience, if you could answer the following question for us. Are you a healthcare professional, a blood cancer patient, or a carer, family member of a blood cancer patient? Just so we know who we're talking to today, because we have had a mixture of people sign up. Right, I think that's enough hearing from me, and let's hear from our lovely panellists today. So the first question I wanted to pose to the group while we wait for the results of that second poll to come in is your reflections on what a specialist nurse is, if that makes sense. Is there a defined role? Is it a defined role, and should it be? And I know that's a difficult question. I wanted to start with something slightly difficult to start with. Kirsty, I wonder if I could maybe ask for your initial thoughts. Yeah, I know, I had to pick on someone first, I'm sorry.
Wow. I think that's a really good question, and I think the CNS role really differs depending on who you're looking after, where they are in their diagnosis, where they are in the continuum. And also it varies a little bit, I think, depending on where you are geographically as well as to what we're able to offer. And I think one of the big things with CNS is able to signpost to the patients. And we can't do everything for everybody, but often we can signpost the patient to the correct service. And I think that's something you learn a little bit with experience. I think I came in as a CNS and thought I had to do everything for everybody. But actually, I learned very quickly that you can't do that, and it is a little bit about signposting patients to the correct service and empowering them more than enabling, really.
I caught most of that. I'm still struggling a little bit with your sound. It's a bit fuzzy and quite echoey. Just if that helps, sorry about that. But I think I picked up most of what you said. I think the key points are it's variable, absolutely variable, depending on where you are and what you've been diagnosed with. Hopefully we can hear a little bit better. Maybe if I come to Caroline next, do you sort of agree or disagree with Kirsty's assessment? How do you feel about the role of a nurse?
Well, like Kirsty, I came into the role thinking I could do everything for everybody, and you just can't. You can try, but you would end up very exhausted. I think that she's right in that it depends where you are geographically and what services are available locally. Each one of us, even on the panel, has a completely different role to each other. So you just, you just work with what you've got, basically. The CNS job plan that was set out for the UK as a whole has been quite patchy in the way that it has been implemented, and that has had been a big problem for patients. Hematology tends to come quite far down in the CNS job plan too, which is a problem.
Yeah, there are certainly policy things at play here, like how it's defined within the NHS as a whole. I agree, absolutely. Maybe then that's a good point to come to you, Sarah, because you technically have two different job roles in your description. I wondered if you could just describe a bit about the difference between the two for me.
Yep, so I was initially employed by the trust I was working for at the time, because we've changed trust from the Royal to Clatterbridge, as a research nurse. And at the time, there weren't clinical nurse specialists in posts. I've been working with leukemia patients since 2002. And I started doing this role in research in 2006. And it was soon very clear that patients needed more from support than just in relation to the clinical trial. We talk about the holistic needs and help referring for financial advice, information and support on treatment, and just to support patients throughout their whole experience from diagnosis right the way through their treatment. So it was finally recognised, and it took a long time for it to change. And with discussions with our management, our job title was changed to being a research nurse and clinical nurse specialist, which recognised the all-encompassing nature of what we do. And I think in other trusts, maybe patients have a research nurse and a clinical nurse specialist, and they might not know who to go to for different things. So it's really good that I'm recognised as the key worker for my patients from when they're diagnosed. I go through all their treatment, the clinical trial. I play a major role in, I don't consent for the trial, but I consent for the treatment. I'm responsible for organising all their care and communication throughout their whole treatment pathway. So it's a really privileged role, and you get to know your patients incredibly well. And it's such a complex, long, uncertain journey that patients go on with so many, we were just chatting today in our clinic about what patients have to live with, and the uncertainties the whole way through. It's very different to a lot of other diseases and treatments. Leukemia is so vast and complicated, and the treatments are so complicated compared, we've just moved to Clatterbridge, and the solid tumours, obviously they work quite differently, but the regimes we give to patients are quite overwhelming, and patients have very long inpatient stays. And yeah, so it's a really lovely role, and hard, definitely, but rewarding.
Yeah, I'm sure it is. Catherine, I wonder if I could come to you to pick up on this confusion between key worker and CNS. Is it the CNS that's more important, or is it a key worker, or is there an element of both there?
So for us here at St James's, that's the same thing. So when a patient is diagnosed, they're given a CNS, but we are also their key worker. So we're that point of contact for them from the moment they meet us at diagnosis right the way through to treatment and beyond that, into long-term follow-up as well. So that's how it works here. I'm aware that in other trusts that might be a little bit different. For us that works because it means that people we're given the physical card with our names and our details, and it says key worker on it. So they're quite clear that means the same thing.
That's good to hear. And coming back to you, Kirsty, let's see if we can hear you okay. Should it be the role, I suppose, of a CNS to be that key worker, do you think, or is there a role that others could play that is similar? So, for example, there's a couple of patients already asking, how do I get access to a CNS? Should I have a CNS? Does it necessarily matter that it might not be someone with that title that they are in contact with?
I would argue that it would be good for them to have a CNS, I think, because, can you hear me better? Yeah. I would argue that it should be a CNS or an ENP. We have the same. We give out a key worker pamphlet, and it covers CNSs, ENPs, senior specialist nurses, just so that people are aware. And I think it's sort of that one continuity that patients have, because often if they come up to clinic, they see somebody different every time, and the key worker doesn't need to do everything for the patient, but they can then at least highlight who can help. So we have a clinical support worker who can help with things. We also have somebody that helps with benefits. So again, it's just that signposting, that ability to have somebody that the patient can turn to and ask questions of. And we don't need to do everything, but just be able to say, I know a person who would be able to help with this.
Yeah, totally agree. I think that's hopefully that answers everybody's questions who was immediately asking, should I have a CNS? If you don't have a point of contact that you are aware of, some continuity, then do sort of ask. I guess a follow-up question then is if there are benefits to having nurses with specific specialisms in certain leukemia types. So some of you have different leukemia types specified in your job titles. For example, Catherine, you says myeloid. So maybe I could come to you first, Catherine. I mean, of sort of being a specialist in a certain leukemia type.
Yeah, so it's the way that our department is sort of divided up into this way the consultant groups we work actually, and therefore we then follow with that. So the way that our team work is we have myeloid specialist doctors who deal with certain kinds of leukemias, including chronic and acute, but then we also take the myeloid disorders, so MDS, MPNs, and that side of things too. And that, from our point of view, I think it's more just, it's historical, it's just how the department's been divided up, and therefore that's where we came in when our roles were formed many years ago, and it just kind of fell within the consulting groups.
Okay, that makes sense. Maybe Caroline, do you have anything to add on in terms of whether there's a benefit to patients in a certain specialist leukemia?
I deal with myeloid patients like Catherine and Kirsty. I think it's very important because the leukemias all have special things that you need to know and special quirks. And certainly, like Catherine, and here in Belfast, the CLLs and the lymphoid disorders all are one team, and then the myeloid disorders and the chronic and acute myeloid disorders are in another team. And I think it means that there's a continuation for patients that if, for example, they have an MPN and they progress through, that they have the same nurse looking after them the whole way through. But the leukemias, depending on your diagnosis, the treatments can be so different and they can behave so differently. So I think it's important to have a nurse that has worked with these leukemias and actually has knowledge of what they are.
Yeah. I mean, continuity is a word that keeps coming up. So yeah, I think we're all in agreement on that.
Sarah has the ideal job because I was a research nurse before this, and she's the ideal job, but she's a bit of both because don't know about Catherine and Kirsty, but certainly here in Belfast, although they have a key worker for the trial and the research nurse, the job is split now, where Sarah does both. So really, for everything else, it's me, but for a research thing, it's one of the other nurses. And it's important to point out to patients that you can have a different key worker at different times of your journey through. So, for example, if you are an 18-year-old TYA or teenage young person with cancer who's diagnosed and then they go to transplant, they may be on a trial. They may have a CNS, a myeloid CNS. They may have a TYA worker. And then they go through, maybe have the transplant nurses and the transplant coordinators, and then back to the CNS or a different one. So it can change as your journey goes through. I think it's important for patients to know that, but I think it's important for them to know exactly who to ring at what time point.
Yeah, that certainly sounds very sensible. I agree. Just to go back to the poll, I think we've got the majority of people here are blood cancer patients. So we will come back to the various stages, I think, and just briefly go over sort of what differs at each stage. What I did want to ask, Kirsty, is since your job title is slightly different in terms of advanced nurse practitioner, maybe you could just clarify if there is a difference or whether it's just sort of semantics in terms of the terminology used. What's your thoughts on that?
I guess my job title is just slightly different because of the way it was set up within Oxford. So I'm able to call myself an advanced nurse practitioner because I've done my prescribing and I've completed my MSc. And so it's simply a job description. So other nurses I work with are senior specialist nurses and they've not done their prescribing or their MSc. For me, it allows, because I manage a lot of the chronic patients, it allows me then to manage them, alter any treatment, prescribe for them. So I like that because I'm able to then impact on them. I don't need to go to one of the doctors for help. So for me, it allows me to be more holistic with my patients. And and I know for others don't use it. So I think it's an individual choice, but I essentially do the same as a CNS, I've just got a different title.
Great, thank you for clarifying that. I think that will help if people are sat at home wondering, oh, have I got the wrong person or something? That's always useful to clarify. Thank you. And just a final sort of question on this topic. Somebody has said that sometimes the haematologist is named as the key worker, and they're wondering if that was rare. Does anybody, Sarah, are you able to comment on that at all?
I guess maybe that's in smaller hospitals, maybe in some district general hospitals where they don't have as much support or resources. Maybe the doctor would be classed as the key worker, but here they wouldn't be the port of call for patients to direct first line. It would definitely be us or the day unit or the ward out of hours.
Is the important thing that people just get the support that they need rather than who the person is all the time?
Absolutely. Yeah. If you've got a doctor who's got the resources and capacity to provide that extra level of support, it doesn't matter that it comes from them. It doesn't have to be a nurse. As long as patients are feeling supported and informed throughout their treatment pathway.
Great, thank you. If anybody does have any concerns, do get in touch with us, but that sounds perfectly sensible. Thank you. Okay, I think it makes sense to sort of move on to talk about the sort of stages of, we can't cover all of them in the different leukemia types, but as broadly as we can, the stages of that a patient may go through along the way, and how the CNS can support during that time. So Caroline, maybe you could start me off on this. What specifically at the point of diagnosis, when someone sort of sat and receiving the first initial news, what is the role of the CNS at that point?
Well, because there's so many of the specialist nurses knocking about this department at the minute, it's probably slightly different from what I would like it to be. And certainly COVID has impacted on it. Ideally, your nurse specialist should be with you whenever you're told your diagnosis. Here, as an inpatient, if you have an acute leukemia, they aren't. And the reason for that is that the research nurse gets precedence upstairs in the ward. We've only recently been allowed back into the ward, and that's with agreement swabs. So the things you do for patients. So up until now, with the COVID, the research nurses got precedence because they were the ones that were there. And if you're diagnosed with an acute leukemia, it's a very short distance between getting your bloods checked to being sitting on the ward and told you need treatment and you need to start tomorrow. And you have an awful lot of information to process at once. So we made the conscious decision, the CNS didn't go up in those early days, just everything had settled down a wee bit. And the patients actually had the physical capacity and mental capacity to actually remember who you were going to be in a week's time. Because certainly as a research nurse, and I'm interested to see whether Sarah has had the same problem. There's been times where I have gone to patients whenever they're newly diagnosed with an acute leukemia and spent hours with them and consented them and they've started their treatment, and I maybe gone up 3 or 4 days later and they know my face, but because there's been so many people in with them, they can't really remember. So I think, much as I would like to be their diagnosis, I think every patient's different, but at the moment it just has to be that's just the research nurse. Certainly, if you have an MPN or you have a more chronic leukemia and you're being told your diagnosis down in clinic, I would be there and telling them, giving them information and giving them my card so that whenever they go home and somebody goes, but why did you not ask this and what about this, that they actually have somebody to come back to with the details and everything to ring. So that's what I do at diagnosis. I'm interested to see what everybody else does.
Yeah, it's a really interesting perspective on the acute patients, and I'm sure, I can't blame them for slightly forgetting who you are in all the shock. Sarah, did you want to respond to Caroline there?
Yeah, so my role is very similar at diagnosis, in terms of that I would hope to be there as long as, unless it's a weekend, or me or one of my colleagues, to be there when the patient's told their diagnosis, and then to be there to support, to give them all that information, talk them through all their treatment. And I think I've been lucky in our trust that with COVID that we have been allowed access to our patients, regularly. And if anything, I've felt the need to go there more, even because patients haven't had that same level of support. So they're not getting visitors, and making sure that we're having conversations, you know, with a partner on a video phone, as we're doing consent chats, as we're doing treatment chats, and trying to more than ever just ensure that they're supported and the communication levels are high with everything that's going on, because it's such a crazy, crazy time. And as you said, it's so much information. You're being told information about a new diagnosis, you're being given paperwork on clinical trials and treatment, and then having to consent a few days after being told all of this. So it's hard to ensure patients are adequately prepared for what can potentially happen in that short space of time when they're dealing with so much.
Yeah, that's something I hear a lot from our acute patients, definitely. Kirsty, did you want to sort of contrast that with your experience of supporting patients with a more long-term diagnosis?
I think we sort of do a bit of everything. So again, through COVID, we've been in most of the time, and my role slightly differs in that I'm the first person in to see people, and I've constantly been in clinic throughout COVID as well. So I've been down in clinic when we've brought patients in, because it's really difficult for the chronic patients having a diagnosis over the phone, particularly if it's been an incidental finding and they feel well. So trying to explain it's so unfortunate, and you miss all the little nuances of somebody being in the room with you, of what they're picking up on having family members there, of what information to give them, because that's a big thing, is how do they want that information? How do they want to process it? We're all different. We have different eye colour, different hair colour. I'm a visual person. You give me a whole load of pamphlets, I'm not going to read them. So I like to be able to personalise the information, and do you want me to phone you and talk this over? Do you want to process it? So I feel as though COVID has really put the kibosh on all of that. And I think we've had to really work hard at finding different ways to support people, to make sure that their diagnosis, they've got a chance to discuss their diagnosis and they know who to turn to. So I think with all CNS roles, we tend to evolve and develop pretty quickly with different things. And I think this COVID's been given us a chance to do that. I don't think we get it right all the time, but I think we're trying.
Yeah, I think definitely seeing a lot of people considering how COVID has changed things and whether that could be for the better as well as for the worse. So definitely, I think that's something we're all trying to do a lot of. Catherine, did you want to sort of comment on your approach to diagnosis?
I think what we do here is very similar to what the others do. So we are present at diagnosis, and that's usually, unless it's a weekend, be it on the ward or in clinic. And then we tend to, especially for those with the longer term conditions, so the MPNs or CMLs, if they're not coming straight back to clinic the next week, then we would usually do a follow-up call as well to make sure that they've at least had a look at the information, and from then you can usually get quite a few questions at that point about what did the doctor say about X, Y or Z, or what did you mean about that, what happens next, and that's usually quite useful. That's been we've probably done more of that actually recently as well because of COVID. A lot of at the very beginning we were doing diagnosis over the phone, which wasn't ideal. That's changed now. People are now coming here to see us, but I think it gave us the idea that actually some of this could be done by phone as well, just that follow-up call to somebody to ask the questions of which bits didn't you understand, what bits do you need me to go through, what more information do you need about something specific, because that will be different for everybody that we see.
And just to clarify, I think a lot of you have talked about sort of discussing the diagnosis and the medical aspects at that point, but do you often do signposting for more holistic care at the point of diagnosis as well? I can come back to you first, Catherine, if I may.
So we do. So the initial discussion for a newly diagnosed patient would normally happens with the doctor, either in the clinic room or in the patient's room on the ward. But then after that, we would then tend to stay with them and talk through the more holistic aspects of what happens next, what the reality will be, things like work, college, university, whatever it is that might be affecting them, people that they live with, and finding out a bit more about them to find out what's actually important to them, what's the bits that's really going to be the problem throughout treatment or watch and wait or whatever comes next for that patient. It's making it very individual to that person.
Great. And Caroline, is there anything you want to add to that in terms of what, at the point of diagnosis, the specific needs patients have that you help with?
Well, I think as nurses, we're a lot better at asking what's going on at home and what's going on outside, their disease than doctors maybe are. So as Catherine says, you then have the conversation whenever they have been diagnosed about how it's actually going to physically impact them and what it means for them on a day-to-day basis, and take it from there.
Great. I'm sure doctors do ask sometimes just to stick up for them slightly, but yes, I'm sure you guys are all more in touch with that sort of thing. Moving on then to sort of a treatment pathway. Sarah, I thought it might be interesting to come to you first in terms of a nurse as well once somebody needs to start treatment, because obviously you've got the research nurse side of things as well. And if you could start with just sort of talking about what a nurse can discuss in terms of treatment, and then maybe how that differs if they were to sign up to a clinical trial, if possible.
Okay, so I work mainly with acute leukemia patients, AML and ALL. So all patients would be offered, I mean, they closed during COVID, but now we're back running to normal. All patients at diagnosis will be offered entry into the national clinical trials. So my role is to basically explain what that means, because patients hear the word trial. Some patients embrace it and think it's a great thing. So other people can be quite anxious about that and be like, oh, I don't want to be a guinea pig, and trying to explain that these are phase 3 trials, they're not early phase, and sort of giving patients a good grounding and understanding of what a clinical trial means and the potential benefits to them being in this trial in terms of monitoring and access to drugs. So, but then also explaining if you don't want to go into it, it's absolutely fine. It's not going to affect your treatment in any way. We're just trying to give you all the options available and ensuring they understand it. Because again, they're quite complex treatment pathways offering different agents, and just making sure that they and their family fully understand what the treatment what options are and what's available to them, and what it means to be in the clinical trial if they choose to go into it. Yeah,
I guess the clinical trial just comes with more paperwork involved and a lot more, of the logistical stuff. But
it might mean something like, maybe it might mean more bone marrows for some patients and some, but generally for the general standard phase 3 trials that most patients go into at entry, it's pretty similar to what you'd be getting if you weren't in the trial, especially if they're registration only trials like the ALL patients at the moment. You know, if you're on the trial or off the trial, you're essentially getting the exact same treatment. Just one of them, that information is going to be collected anonymously and then hopefully help improve treatment pathways going forward.
Great. And Kirsty, maybe I could come to you to see whether Sarah's made it sound as if it's sort of a lot of managing expectations. What might happen once you start on treatment? Do you say that's a fair assessment of the nurse's role in treatment?
Yeah, I think when I meet somebody for the first time, what we have to remember is this is an acute situation, and often they're in as an emergency, and the treatment options aren't, it's a bit of they have to have treatment, because otherwise they're facing their diagnosis, and leukemia, acute or chronic, out of control, is going to end their life. So sometimes patients are faced with their own mortality, and then all of this information that they get in. So I tend to try and break it down a little bit into chunks, and often I say that I'm there, the consultants are the house, and I'm there to add the soft furnishing. I'll give them the information when they want it, how they want it, and break it down for them, but also be there to support them as well, because I know what I would be like. I would be an absolute train wreck if it was me in a bed, and you just need somebody to say, actually, this is normal. This is not how you planned your life. This is not where you expected to be. This treatment where you're given a lot of statistics about things, and it's just trying to make that more relevant to their situation and help them deal with it, but breaking it down to different parts, different cycles until they have more information. And so it's really, I think often people just can't process it probably until they're a good couple of weeks into treatment, until they're either in a better place mentally or physically. And often it's actually the physical place that they feel better, and mentally we then have to deal with it. And that's just part of dealing with them as a whole.
Yeah, definitely. Someone's asked an interesting question that I can't stop looking at because I think it's quite a challenging one. They basically asked, with patients being so different and also with often sort of a number of treatments to choose from, how are all those things taken into account at the point of treatment? I wonder, I'm going to have to pick on someone. Caroline, maybe you could comment on that.
You're going to pick me. I think each individual patient is looked at as an individual case. So you look at their physical things, what other things are wrong with them, their social circumstances. There's no point in giving somebody something or offering them something if they're going to spend they're going to travel 200 miles for it and they've got a heart complaint and that this is cardiotoxic. So you look at the patients. Probably one of the times that the patients are really looked at by the whole medical profession as a whole. The whole department sits down and looks and says, right, okay, this is an option, this is not an option, and take all the other things that are wrong with them and their family histories, cytogenetics. There's a lot of things that depends very much on the disease and what's available and what is available for that particular type of leukemia or illness. And then narrowing down the options and presenting the options to the patients with any information they have. And the patients always want, as Kirsty says, there's always statistics, and patients hear lots of statistics. And then one of our old consultants used to say, I can tell you what will happen to 10 patients, but you don't want to know what happens to 10 patients. You want to know what's going to happen to you, and we can't tell you that. And that's the difficult thing, is that you can't say to somebody, well, if you take this treatment, I know you're going to be this or this, because it's just impossible. I have seen lots of patients in my time, and I'm sure the girls are the same, where on paper it looks like they're going to do really, really well, and sadly they're no longer with us. And then there's other people that you just think, how are they still here? But everybody's individual, and you need statistics to guide you, but they're not the be all and end all. So one thing I would say to patients, and say to them regularly, is yes, think of the statistics, but don't make it wholly your focus.
That's a really important message. Thank you. And the group you mentioned there, just before we moved on, the group of sort of doctors and nurses that all come together, that's known as the multidisciplinary team, or the MDT. Is that what you were referring to?
Yes. So each patient is discussed. Each patient that's diagnosed with a cancer, regardless of what it is, has to be taken to a multidisciplinary meeting. And there you will have, in the case of leukemias or MPNs, you will have laboratory staff. You've analysed samples and looked at the cytogenetics. You will also have histopathologists that have looked maybe at samples that they've collected. You will have haematologists, you'll have research nurses, and you will have the nurse specialists that are there to speak for you. And your case will be discussed. And sometimes you may have already started treatment, especially if you've been acute leukemia by the time you come to the MDT. But it's just the decision is looked at and ratified, and a plan is made for your care going forward. And then a copy of that plan is sent to your GP. So if you want a copy of that, it's easy to ask for. It may not make an awful lot of sense to you. And I will say to patients, especially if you're in acute leukemia, you look to the next cycle. You just one day at a time, because things change so quickly. So you can be discussed at an MDT, as we call it, more than once if something changes, or you relapse, or your CLL that has been on watch and wait and now looks like they might need treatment. Then you'll go to discussion with the MDT before they start, and they will make a decision together about what's best for you.
Thank you for clarifying the MDT. I'm sure that's a phrase patients hear a lot, and not all of them will understand what it means. It's really helpful. Maybe I could come to Catherine and then Kirsty. We've had a couple of questions from people on with more long-term diagnosis like MPNs and the role of a nurse on a more long-term basis. Catherine, would you mind commenting on that for me?
Yeah, of course. So patients with a longer term condition, and for us that would mean patients with CML, which we look after, and MDSs, the low risk MDSs and the MPNs. So they have a very long follow up with us. It could be 20, 30, 40, a lifetime, potentially coming to clinic and having bloods and medications, etc. So our role differs a little bit in that we don't see them as frequently. They don't need us generally because many of them are okay to go and work or do whatever it is that they want to do, but they have our contact as that, if something happens or when they're next due in clinic, they want us to be there for a certain reason, and we're available. We also run nurse-led clinics for many of those patients. For those that are either on very well-controlled counts, are very good, they're on a steady type of medication, then they're on nurse-led clinic, which means that pulls them out of the doctor clinic. That frees up space for the doctors to see other patients, including new patients, and it means that they build up that relationship with us so that they know who to get in touch with if they're concerned about anything. So that's a little bit different with the acute patients. They would always see the doctor when they came, although we would be there too. So that's a bit of a difference in the way those two areas work.
Great, thank you. Kirsty, is there anything you wanted to add from your experience? Do you also run nurse-led clinics for longer-term patients?
Yeah, so we tend to manage most of the MPNs, the MDSs, the CML patients in our nurse-led clinic. It's changed slightly with COVID, just how we manage people, because we've had to change roles slightly. But actually, they're probably the group that I like managing the most, because I think quite a lot, they have quite significant symptoms, and maybe these symptoms haven't been explained to them. And for years, we've tended to look at what the blood count is and not necessarily act on any of the symptoms. So that's sort of my area of interest, so I could wax lyrical about that forever. So I tend to be, and my colleague Caroline tend to be the main contact for the MPNs. They're maybe diagnosed in clinic and then straight into our nurse-led clinic for management. Then we bring them back to clinic maybe every 18 months to 3 years, depending on their diagnosis, depending on their bloods. But it just gives us an opportunity to work in with the patients, because a lot of them, they have 9 to 5 lives. So us bringing them up to clinic during these times doesn't work for them. So it's finding out how to contact the patient, how they like to be contacted, how they like their bloods, but also setting a little bit of boundaries in that if bloods aren't as good, or if we're a bit concerned, how we have these chats and if they're happy to have them over the telephone or over email. But also then being able to assess their symptoms, be there if we have a rule that if they're just not feeling as well, they have their blood done a bit earlier and just let us know. So it's a very different way of managing the group of patients. But again, still same with Catherine, knowing that they have somebody to contact, and we can always get them back into clinic relatively quickly.
Thank you. And we have had a couple of people ask you about being on active monitoring, which largely applies to CLL, but I know does apply to MPNs on occasion. So if you wouldn't mind commenting on that, Kirsty, I mean, what do you find you often have to support those patients less or more? Or
I think it really varies. It really varies because, you're given this, people are given this diagnosis of a watch and wait, and it doesn't make it any less difficult to tolerate. So sometimes there are peaks and troughs with it. And often I think they're told their diagnosis, and then maybe a little bit later they have questions. So I find that it really does vary as to when they need support, and just knowing that you're there to help support them is often just what they need. And it varies at different times with different stressors. If they're unwell, the first thing they think is, oh, my disease is back. And often it's not the case, but being able to speak to somebody and just have somebody either reassure them or say, actually, let's check your bloods early so that then their anxiety is not increased. So yeah, I don't think there's something. I have said before, sometimes I think with acute diseases, there's a very clear pathway for them. And whereas with the chronic diseases, there's not as many resources into them. So I do find it can be a little bit more difficult for people with a chronic condition.
Yeah, our work certainly shows that there's far less resources in terms of nurses and all sorts of people to support chronic patients. I totally agree with that. Just want to say at this point, there's been some lovely comments about the great work that CNSs like yourselves do to support patients. So I hope you've seen some of those. They're very, very nice. It's always good to have those kind of comments. Sarah, I wanted to expand a little bit on the clinical trial. So you talk quite a bit about your role at the point of deciding to join a clinical trial, but I don't know if you feel that, does your role perhaps differ between how you have to support people who do sign up to a clinical trial versus those who choose not to? Is there much of a difference a bit further along once they've decided to join in terms of the support they need?
I'm not sure really. If a patient doesn't go on a clinical trial here, they'll generally move to we have a team of specialist nurses just to a different specialist nurse who'll follow their care and take over at that point. So yeah, I think for me, in my role, I support patients all the way through their journey. And again, we're quite lucky because even if they come off a trial and their treatment changes, we generally keep hold of them because we've built that relationship and we know them. But again, I know it's very different in different trusts, and things can change within that as well. But generally, I'm there to all the way through their treatment, make sure that they're getting samples sent at the right time points, that the appropriate treatment discussions are happening at the time points they need them. And again, if patients go to MDT at the right points, and just keeping track of them. The point I generally lose patients temporarily is when they go to transplant, because they do, as Caroline said earlier, that the key worker does change. So we talk about passing the baton and explaining to patients at this point, I've got experience in transplant, but I'm not going to be responsible for that phase of your care. But then our patients do eventually come back to our clinics when they're past the intense transplant phase. So we do pick them back up later on, which is nice.
Great, thank you. I wonder whether maybe Catherine, because I think this applies more in sort of more chronic and long-term conditions, whether you could say something about the role of specialist nurses in liaising with primary care as well. Is that part of your role, and if so, is it particularly challenging?
Yes, it is part of our role. So we are frequently in touch with the community, GPs in particular, for patients with longer term conditions, mainly in relation to symptoms that can be managed in the community, and also monitoring blood counts or effective medications that they might be having. It can be challenging, I guess. People are really busy, especially in the community, especially over the last year or so. I think it's been extremely difficult for them, so that has been more difficult. But I think in general, once we build up a relationship with a patient's GP, and they do too, I think explaining that they've been diagnosed with a blood condition and this is what's going to be needed, I do think they're a lot more willing to engage with that and understand why we're asking what we're asking, what's important to look for, what things aren't likely to be a problem, therefore they could deal with just themselves by the GP, and also be a source of information, a resource for the GPs, because they won't necessarily know a great deal about these conditions. They're very rare, and they're for the main part. So I think it's useful for them to have our details, which we try to make sure they do. Right from diagnosis, so that we can be there to support them, support the patient in the community.
Great, thank you. I wonder whether you could comment, Caroline, as you support quite a range of different conditions in your role. Is there any difference in terms of the support you need to provide to primary care depending on what leukemia type patients have?
Well, certainly the GPs, whenever they have an acute patient, they never ignore blood counts again. Usually cares them. and they're quite happy to hand over anything. So I think there's a big area of learning that the GPs need from that point of view, and they're quite happy that if somebody has a diagnosis of an acute leukemia, they leave it all up to haematology. As for the chronics, things like the MPNs, the CLLs, the CMLs, it's about, as Catherine says, building a relationship with the GP, because a lot of these patients are looked after under shared care guidelines, where we ask for the blood test, we prescribe the hydroxycarbamide or whatever they're getting, but the GP is actually dispensing it out to them or writing the script for it. So there's a lot of times that you need to support, whether it be district nurses, palliative care nurses, GPs, about their patient, and there's a lot of learning involved. But as Catherine says, these are such rare diseases in comparison to, say, lung cancer or breast cancer. There's a great need there for GPs to learn. They maybe only see one or two patients in their whole professional career. So we like to be there to show them, or if they need to bring us for advice or whatever. And it's nice for the patients to know that the GP has somewhere else to phone if they're not sure. Because time and time again you hear, certainly patients with MPNs, the patients say, well, my GP hadn't a clue about this condition or what it was about. So yeah,
it must be very challenging for a GP to have to understand quite so many different illnesses, I'm sure.
It's in the title as a general practitioner. They need to know a little bit about everything, but we're the specialist blood. We're lucky we can do it all the time, but they don't have to. That's why we are here.
Absolutely, yeah. Interesting questions come in from Facebook about support available at weekends. So there's a CML patient who says she finds, or they, doesn't say she, apologies, find 111 and various things helpful, but they wondered what they should do if they wanted to speak to someone at weekends. Kirsty, if I may come to you, are you generally available at weekends, or is someone within the department? Does it vary by location? I may ask some other people as well to comment.
I'm not available at weekends, but it is something I'm very aware of, that historically we were never available at weekends. We are very, very fortunate where I work to have a triage service that covers weekends, or patients can phone through to the ward. But again, like with many different diseases, you do run the risk of getting somebody that is there to triage emergencies, mostly looking out for neutropenic sepsis, sort of oncological, hematological emergencies. So somebody just phoning in for general advice or with questions, it can be difficult. So often what I say to patients is, either if they have questions over the weekend, because inevitably your questions are going to come up in the middle of the night when you can't sleep, not at the hours of my work. So I say just email them or phone me and say, I have some questions, can you phone me? So that then I can then act on it, rather than them worrying. Because if they're anything like me, I worry about the little things and just manage with the big things. But if you worry about it, all it's going to become is this big mountain for you. So they just need to know, and it's a bit about expectation management as well, because there's only one of us and there's lots and lots of patients. So it's a bit about saying, we can't be here all the time, but if you have an issue, we will try and get back to you as soon as we can. So giving them the options of how to get in touch.
Great, thank you. Sarah, is it the same for you in terms of availability at weekends, and would you echo Kirsty's advice in terms of, if something does come to people, when should they ask?
Yeah, I mean, it depends on the acuity of the question, doesn't it, or the concern. If someone's got a temperature, it's different to, wanting to understand something that they haven't understood in a clinic consultation. So yeah, we don't, the CNSs don't work at weekends. We do have AMP support at the weekend, and all of our patients on any cancer treatment will have a chemotherapy card which has numbers they can call during the day and out of hours. So there's 24-hour numbers that all of our patients have. Again, you'd encourage for the smaller non-urgent questions, that's the word I was looking for, urgency. You would say, could you just, make sure you write. I mean, one thing I'll always say to patients during consultation with the doctor is, prepare questions, write them down so you don't forget, but then also when you go home, write things down so that when you come to us, that you're not going to walk away and go, oh, I forgot to answer that. I think it just helps you process your thoughts and your questions better. But if it's something urgent and someone's acutely unwell, has got a temperature, all patients are given 24-hour contact numbers.
Someone has just quickly popped up to say, is there one preferable way for all CNSs? Which I'm guessing the answer is probably no. But does it come down to urgency again in a way, Sarah, for you, in terms of if it's urgent, phone, if not, consider another method? Absolutely.
And since I've moved to this new trust, I mean, I never had a mobile phone before, and we had an office phone. And again, if someone leaves a message, you can't always guarantee you can get back that day. And it's quite different now that patients can access you quicker, but obviously you can't always answer your phone. So if it's urgent, like on the end of my answer phone message, don't leave a message, call the emergency numbers you have, and don't expect, that I can always ring back the same day. So if it's urgent, always make sure that you don't think, oh, she'll call me back in 10 minutes or wait, because obviously with sepsis, rapid treatment is essential. So you need to get proper advice quickly if you're not well.
Yeah, I think that's good advice. Thank you. I hope that answers the person's question. Someone's also asked
the nurse what they prefer. For
yes, that's
queries,
also good advice.
What they prefer. Some nurses quite like emails. Some nurses, I mean, I find text difficult because a lot of the younger patients like texting. But again, if I'm off for a reason, you don't get an out of office when someone sends a text. And then I come in and then I've got these texts and I feel bad because I've not replied. So at least if it's an email, you get an out of office, or at least if you hear you ring somebody, you get an answer phone message. But I would say to patients, be wary texting, because if for any reason your CNS is off, you're not going to know via a text reply.
There we go. Great advice. Thank you. Another quite interesting question we've had is about access to reliable information, which I thought was a good point to bring it up, because we've talked about how someone might not be instantly available. Caroline, do you have any advice for people in terms of where to go for information or advice if they can't get an immediate answer from a nurse, and they just, to avoid them Googling, let's say, which I know is the one thing that you always advise against?
Off the internet, there's a lot of sites out there that look like they're legit and they're not. So if you can't get your CNS and you have something that's not urgent but is troubling you, like the rest of the girls, I would say write everything down. I do respond to emails. I did used to have an answering service on my text, and the program is gone. It was a great job because we were able to set an out of hours office on a thing, and now I have lost it whenever I change phones and I don't know where I can't even remember what it's called. But if you're looking for information, stick to the like of Leukaemia Kerr, MPN Voice, something that's relevant, a charity that's relevant to your condition. And write your questions down and look at it. And if you can't get your answers from those websites, then leave a message or email your questions to the CNS, and she will come back to you. She just mightn't just do it today, but she will come back to you. But stick to the websites.
Yeah, that's something we come up against all the time. Google is not always your friend. I think we're probably approaching the end of the discussion now. So for everybody listening, if you do have a sort of burning question that you want to ask, let us know in the next few minutes, and we will try to get to it. I have noticed a couple of questions of advice about COVID that's not sort of what we're going to discuss today. Sort of sticking to discussing the role of the CNS. So if you have any questions about advice for COVID or lockdown, give us an email at Leukaemia Kerr and we will direct you to the right place. But that's not on topic for today, I'm afraid. So my next question, and sort of the final area of topic I want to talk about, is a little challenging perhaps, but I was wondering if I could ask each of you to maybe reflect on what you think the challenges are for haematology nurses sort of now going into the future, including COVID, but also sort of from before COVID. Maybe Sarah, we could start with you if you don't mind.
So just to clarify the question, just challenges of us for us being a CNS, really.
Yeah, definitely.
I think time is probably always the biggest challenge, and workload. Having support as well, because CNSs also need support. So to make sure you've got a good team supporting you, working with you, you're working within where you feel comfortable and what you're capable of doing, and developing your role further. You know, again, we've been able to extend our roles, you know, undertaking bone marrow biopsies, on prescribing. So there's a lot of room for development within those roles as well. But yeah, just to, yeah, it's a hard question to think, you know, what are the challenges. But yeah, I think just time management, being organised, and obviously COVID's had a massive impact on all of our workloads, working patterns, and how we work, and just be open to develop and learn and change and grow and keep trying, because that's all we can do.
Great. I think workload is an important one, and obviously we would all like to see some more CNSs come into the NHS wherever possible, and less workload. Sorry, carry on.
I was going to go back to one of the questions you said earlier about, you know, if you have, do you need a CNS to be that person, to be your source of support or key worker? But I think, like, the cancer plan did recognise, again from previous surveys, that it is advised for all patients to have a CNS. So I would be questioning for patients who don't have one to speak to their trust about it, you know, and say, who is, you know, make sure you know who is your key worker, who is your source of support, because it does make such a difference.
Yeah, I think, you're right. There's been reports that say that the biggest driver of quality of life for patients is access to a CNS. So there clearly is something about the CNS role that is unique, and that we should all value and therefore make more of. I absolutely agree. Catherine, maybe I could come to you next. What are your reflections on this?
I think very similar to Sarah, to be honest. It's the time, it's the number of people that we want to be able to support, and be able to do that, and to give people enough time when we do meet them, not just at diagnosis, but all the way through. If someone comes with a specific problem, I'd love to be able to spend, you know, an hour or 2 hours just digging into what really needs to be sorted out, and sometimes it's just not always possible to do that, and that makes me, it's frustrating, that you feel that you can't do the job as well as you want to do it sometimes. I think sometimes, especially recently, the issues with communities, so local community and GPs being extremely stretched with lots of other problems, and that's thrown up an awful lot of issues for some of our patients getting the right support close to home. That's been very challenging for them, and that continues to be an issue, and I don't see that changing, I don't think, at the moment. Interacting with social care as well, you know, patients needing support from that side of things is extremely difficult. Those patients that we give chemotherapy to, who then need more support at home to get over that, getting that support in place can be really challenging, depending on what the local services are able to provide at that time, and that seems to be getting harder at the moment. And then the other thing for me is the ever-changing types of treatment that we give, how we're looking at certain diseases. That seems to change on well, it was weekly for a while, and now it feels like it's maybe monthly as new treatments have come out, which is fantastic. Targeted treatments for those patients with acute leukemias, or different types of treatments for those with longer term conditions. And it's making sure that we're educated about that we understand more than well enough to be able to then explain to the patients and their families about the treatments and the pathway that they'll be following, and how that was actually different to what they may have had even a couple of months before.
Yeah, I think keeping up to date, I appreciate, is a very big challenge. I also find it difficult, and I do it day in, day out as well. So I'm sure it's even harder for you doing other things as well. I'm sure it is. Yeah.
I would also say that that's one of the things about the job that I do love, and that's one of the reasons I like my job so much, is because it is always changing. So it gives you that challenge, and that's actually part of why I like it so much. So although it's difficult, I'm glad I'm able to do that.
Great. Kirsty, how about you?
Same as the others there. I guess the big thing for me just over COVID is the fact that often there's only one of us in service, and there's a lot of patients, and our patients we don't have the same attrition we did before, so patients are living longer with longer term conditions, and sometimes you feel as though you are spreading yourself really thinly and maybe missing things, and I'm very acutely aware of that. And I think that's going to be the biggest challenge, is being able to help patients and the CNSs support patients from the acute phase into the chronic phase, particularly as we are extending that chronic phase significantly for patients. The psychological challenge, the fact that access to having somebody that can talk about the impact that a diagnosis has is ridiculously bad. And I think that's a huge, huge thing. And there are changes being made about that, which is great. Leukaemia Kerr obviously do counselling sessions for patients. And again, that's another thing that I'm aware of, that we don't always have people that we can signpost patients to. We are starting a service, but we're so behind with this, and it's a huge impact. But also being able to empower the patient with the longer term conditions, being able to put the power back in their hands. So we can guide you with your treatment, but you take back some of the control, and how we can best support that, through like breast cancer, cardiac, they all have better ways of managing your conditions, and we don't really have an awful lot like that in haematology. So I think that would be a challenge that we're going to face.
Absolutely agree. Thank you for that, Kirsty. And Caroline, anything you want to add there?
I'm a bit longer in the tooth than everybody else, probably. So I can see very clearly, certainly years ago, patients weren't well enough or weren't here to need counselling. I see coming up in the chat today, people saying that they have PTSD from treatment 20 years ago, or they didn't know who their CNS was because they were diagnosed years and years ago. And that's a problem. That's a real problem, because although we are dealing with the patients that are coming now, there are patients that are still knocking about, because I always say to my patients, you'll be looking at me to the day you die, regardless of what that is. And we do, haematology, hang on to our patients. We're supposed to discharge them, but we don't. And I think that there are more patients living longer with chronic conditions, and that is fabulous. But there are patients out there that have had treatment for leukemia years and years and years ago, still have some issues, and could deal with some counselling or long-term effects, say, of transplant and things like that. And I think to get the word out that there's a CNS available for those patients as well, albeit that's given us maybe more work. But I do think that there is a big body of work there. There are lots of people out there. And as Kirsty and the girls have said, there's only one of us and there's loads of people. And you really worry that you're missing somebody that really, really needs you. You lose sleep about it. But there's only so much you can do to promote yourself, especially in the post-COVID area where there's not as much information about the outpatients department and everything, and we can't give out leaflets just as much, and people don't want them anyway in case we've all got COVID. There's raising an awareness. So if you don't know who your CNS is, or you've been diagnosed for years and you feel that you have, quite rightly, some PTSD, because we didn't get it right in those days either. Like we're transplanting patients now, and years ago, whenever we transplanted patients, they were in for weeks and weeks and weeks and weeks. And, if they were diagnosed with a problem now, they possibly wouldn't be transplanted. So if you do have issues, to go back to your department and see if there is a CNS, because just because you were diagnosed 20 years ago doesn't mean that you don't have access to the CNS now. And that'll be a big challenge for us as patients live longer. Our workload's going to exponentially grow. But
Yes, that's something for policymakers to worry about. We just need to worry about getting our patients all the support that they deserve. So before we get into that political debate, I think that's a nice place for us to end. Thank you, Caroline. I think you've raised some really important points there. And Kirsty, about mental health, which we, as Kirsty says, are trying to address in a small way through our counselling fund, but obviously wider change is definitely needed in that area. Thank you, ladies, for a really, really interesting conversation today. I hope everybody listening, whoever you are, whether you're a trainee nurse, or whether you're a nurse, or whether you're a patient, has found the conversation useful. A couple of you have asked how to get in touch. I'm about to show some slides in a moment, which will have our contact details on them. So do take a note, or this webinar is being recorded, so you can go back and look at the end and take a note at that point as well. And someone's asked about support groups. We do have an acute leukemia support group. I believe the question is about acute leukemia. Again, you need to look on our website or get in touch, and we'll direct you to the right place for that one. I think I've covered all the questions in the chat box. So just to finish off quickly with overview of the services we have here at Leukaemia Kerr. Range of information sources. We've been running a lot of webinars recently. We've got one on treatments for CML coming up, and one around exercise and how to exercise safely with a leukemia diagnosis also coming up. So that for more details on those, see our website. The next slide, please. Can I have the next slide? Perfect. Sorry, go back one. I didn't notice it changed. Apologies. Thank you. So in terms of getting in touch and support services, we've got a whole range of, Kirsty very kindly mentioned our counselling fund there at the bottom. We're running our support groups virtually still, hoping to return some of those to face-to-face soon as well. A variety of services, but one I did want to mention in particular, next slide please. Thank you, is the advocacy service. So if you are sort of coming away from this webinar thinking, I'm not sure I have a CNS, or I'm not sure how to get one, and you don't know who to turn to and what questions to ask next, our advocacy service is the people to come to find out more, and we're here to sort of answer those questions, to give you advice on who to contact. So do email us for more information on that. Next slide, please. I also wanted to mention for the nurses listening, we do have an e-learning platform that you may find useful. We've been adding new courses regularly, and we are planning our first webinar soon as well, hopefully in the next couple of months. So do search e-learning on our website or email our communications. There should be an S on the end of that. Apologies, communications@Leukaemia Kerr for more information on our e-learning service. Next slide, please. And I'll leave this up while I say thank you again to our panelists. It was a fantastic conversation. Thank you everyone for listening today, and hopefully see you all at the next webinar. Have a good afternoon.
Thank you.
Thanks, guys. Bye.
Thank you. Bye.